Good morning. Welcome to ANZUP in Conversation. It's Ian Davis here. And I'm really privileged and proud and delighted to be able to talk with Dr. Alicia Morgans from Northwestern University in Chicago, Lurie Cancer Center. Alicia is an associate professor of medicine. She's a medical oncologist and clearly with an interest in genitourinary cancers. She's also a truly wonderful person. It's fantastic to have her here as part of ANZUP. So welcome, Alicia.
Thank you so much, and what a kind introduction. I'm really honored to be here.
We just wish that we could have you here in person, but we'll try to make some sort of arrangement for that in future. So Alicia, I've been working with you on a number of different projects over the years, and you've got a broad range of interests, but themed around patient-reported outcomes and the patient experience, particularly in prostate cancer. This morning, if you don't mind, I'd love to hear a little bit about some of the work that you've been doing with androgen deprivation therapy and cardiovascular outcomes. Can you tell us a bit about that?
Yes, of course. So I think, it's important for us to remember that cardiovascular outcomes are actually a leading cause of death, a competing leading cause of death for men with advanced prostate cancer. And it seems to go back and forth almost in terms of risk of death from prostate cancer if the prostate cancer is the more aggressive of the two. But many men, if they don't die of prostate cancer, will actually succumb to cardiovascular disease. And so understanding how we may be enhancing that cardiovascular risk or making it worse, or how we might make it better, I think is a really important part of how we care for the whole patient. And certainly removing that risk factor, if there is a way to do so, is a way for us to help patients live longer and better, which is of course one of our main goals. So I have worked over the years with a number of groups trying to gather some data where we can, although cardiovascular data can be challenging to obtain in a prospective fashion. And actually there have been a number of trials that have tried to get off the ground, and one that a phase 3 that I believe is paused in terms of enrollment at this point because of challenges of using a cardiovascular primary endpoint in patients with prostate cancer. But there has been a fair amount of data in cohort studies and in the studies around retrospective data collection, where we do seem to find this association between ADT and this increased risk of cardiovascular events, even in the intermittent use of ADT. So our group has looked at ways that we might try to mitigate those risks, and without having prospective data to do so, just kind of come up with a common sense approach that we call the ABCDE approach that hopefully can be relatively easy to understand. So thinking about awareness and aspirin use when appropriate, because that's something that's not always recommended at this point. Certainly thinking about blood pressure control for B, cigarette smoking for C, cessation, of course, of cigarette smoking. D is diet and lifestyle, and trying to control diabetes as well, and recognizing diabetes should it exist. And E is exercise, so getting that physical activity. So use of those kinds of efforts in counseling men can be, we think and hope, very, very helpful. But the prospective data is a little bit lacking, other than one phase 3 trial that actually did complete that we can chat about if you want, with the relugolix new oral GnRH antagonist.
Yeah, I'd love to dig into that a little bit more. So there's this, obviously many of these men in this age group have got other risk factors or even pre-existing cardiovascular disease, but there's this interesting story that's emerging about possible differences between agonists and antagonists. Can you fill us in a bit about that?
Sure. So there's actually been a number of phase 2 studies and some other observational studies that have suggested that GnRH antagonists may have a lower risk of cardiovascular events when used as compared to GnRH agonists. And, I think we've been using agonists for so long and in such large quantities that we have been aware that there may be an increased risk of cardiovascular events, but without an alternative or a comparator, it's hard to know whether this is just the slight increased risk from baseline for this elderly male population, or whether it is truly related to the drug itself. Degarelix is a GnRH antagonist medicine given once a month, used less frequently in the US than the longer acting formulations that are the GnRH agonists. But the phase 2 data that it's been involved with has suggested this lower risk of cardiovascular events. Relugolix was tested in the HERO trial, a phase 3 trial that was a randomized controlled international trial, recently presented at ASCO and then published in the New England Journal, that among other outcomes did have these major adverse cardiac events as one of their AEs of interest. So it was a pre-specified adverse event of interest. It wasn't that the trial had a primary endpoint of adverse cardiac events. It did have actually testosterone suppression as its primary endpoint, but it was this pre-specified adverse event of interest. And in this population of men who enrolled, maybe 70 to 90% of men actually had pre-existing cardiovascular risk factors in this all-comers population that of course had to be fit enough to get into a phase 3 trial. So some of our fitter men still had these pretty significant cardiac histories. When relugolix was compared to the GnRH agonist leuprolide, there was actually about half the risk of these major cardiac adverse cardiac events in the first 12 months of follow-up, which was surprising to me because it was interesting that there were so many adverse events that they actually could find a signal difference between the two agents. So at least we know that this drug, relugolix, seems to have a lower risk in the first year of major adverse cardiac events. And given the data that we have from phase 2s with degarelix, I would imagine that there's probably a class effect, a GnRH antagonist versus agonist effect. So whether we have access at this point, at some point in time, to relugolix, the oral GnRH antagonist, or whether we simply think about using degarelix, our GnRH antagonist, that's the injectable. I do think for patients who are at high cardiovascular risk, this is an option that we might want to think about more often.
Any thoughts as to what the mechanism of that difference might be?
So I have thoughts. I think a lot of us have thoughts, but you really bring up a wonderful and important point that if we find such a difference, I think it's incumbent upon us to really understand the mechanism of action so that we can enhance it further, or at least understand why it's happening in the first place. So there hasn't been the basic science behind this to really define that so clearly, although some people think that it may be related to an FSH surge that happens with a GnRH agonist that does not happen with a GnRH antagonist. Although that's not, again, been borne out in clear modeling and in patients. Although certainly within the HERO trial, they did find that there was a bit of an FSH surge with the agonist, as we would expect, not with the antagonist. It's not clear that that explains the whole picture, especially since the absolute value of the difference between the FSH levels seems relatively low to me. Some have hypothesized that it might actually be androgen receptors that are experiencing the agonist actually directly within the vasculature, or maybe on the cells of the heart itself. But again, it's just not entirely clear. And some of the basic science that's been done actually suggests the opposite effect in terms of changes in blood pressure and things that wouldn't necessarily seem to be associated with lower risk. So the work still needs to be done. Would love to partner with you and the team at ANZUP if you have interest in that at some point in the future too, Anne, but it is something of importance.
I certainly do have interest in those sorts of things, which is a really nice segue into the next set of questions I wanted to talk to you about, which is your broader interest in patient-reported outcomes and patient-reported experience. Can you tell me a little bit about what you've been doing there and where your interests are?
Sure, and thanks for asking. So I think that the lived experience of a patient with prostate cancer is one that is best asked of him directly, and we use all kinds of ways of trying to measure that indirectly, using clinicians' report of adverse events, or even just our vital signs. But to really understand what the patient's going through, we do have a number of questionnaires that we can use, these patient-reported outcome measures, or PROMs, and integrating them into our clinical trials is certainly of high importance. And you at ANZUP have certainly done all of that, but also thinking about incorporating them into our clinical practices is something that might actually pick up at 50% more symptoms and side effects that people are experiencing that might be addressed and improved if we take the time to ask. But time is always of the essence, as you know, in these visits. And so understanding ways that we might use this data, these patient-reported outcomes between visits, or in a more time-effective way, and of course effective in treating the symptoms is something that has been of high interest. And so actually partnering with some folks from Australia and actually a larger international group related to the Ironman project in Movember, we've been able to, in the last year or so, put together a project where we're going to be asking patients within the Ironman registry between visits how they're feeling, get those reports back to clinic, and use some artificial intelligence, computer-based mechanisms to provide some self-supportive information for patients to guide themselves to feeling better with some symptoms. And if they're more severe, to really notify the clinics directly rather than having the patient take the time and that extra energy to actually reach out, because sometimes men or anyone might just not know that it's important enough to reach out and ask for help. So using these technologies, we're hoping to see that we can implement this and improve quality of life and maybe some other outcomes, as was shown in Ethan Bosch's study from Memorial Sloan Kettering, specifically in a prostate cancer population. So that's one, and Australia certainly plays a large role in that. We'll have some sites and has certainly some of the brain power behind the idea, and Movember is of course the support. So we are sincerely happy to partner with everyone.
That's great. Yeah, the real challenge is getting that information back and then incorporating it into modifying the treatment or support plan. But we'll settle for any sort of intelligence, artificial or otherwise.
I agree, but if it can be automated and we don't have to do it, and nurses don't have to spend extra time, or whoever it is that is in your clinic to take the time, it's so important, because in that trial that showed this improvement, not only in reduction of hospitalizations and improvement of quality of life, it actually, of course, showed improvement in survival. There were actually people who were hired, their whole FTEs who were hired to respond to all of these patient concerns, and that was their only job. And it was an important job, but it's not a job that's necessarily scalable across many health systems.
Thanks, Alicia. From Australia, we've been watching what's been happening in the US in terms of the COVID pandemic with real alarm and fear for our friends and colleagues over there and everybody involved. Can you give us a little bit of personal perspective about what it's meant for you?
Yeah, and thank you for asking. And I know that you've been doing well, at least in Melbourne and across Australia. You've been doing well, and I'm glad for you. I hope we're going to go in the same direction at some point soon. But the cases have certainly been rising here. In our clinical practices, we are not allowing any visitors to come in with patients anymore. We had been allowing that more over the summer, but are back to no visitors and minimal visitors in the hospital too, which is actually one of the hardest things is as our cancer patients end up in the hospital and then they don't have support around. It can be, I think, one of the most challenging things of their diagnosis and their experience. We are very happy and grateful to have access to tests and to a phone triage system that now has been in effect since all of this started. So we at least have the mechanisms to hopefully keep patients who are overtly positive out of the clinics and to support patients who are positive and try to do that on an outpatient basis without them getting into the hospital. And the other thing is that, you know, our patients luckily are so conscientious and aware that they have cancer, aware that they're at highest risk. So don't seem to have very high rates of our own patients going into the hospital. But it has certainly changed the experience of just living here in Chicago, living wherever COVID levels are high. And we look forward to a time when things will be a little bit more back to normal.
Has it altered the type of care that you give, and also thinking about clinical trials? Has it altered how those are conducted?
Well, I'll start with trials because some trials have been really severely affected, including some of the trials that I do on cognitive function and quality of life in standard of care treatment of men with prostate cancer, because these non-interventional trials basically were paused for many months. And although we at our center have gotten some of them back up and running, in multi-center trials, we find that there are many centers that are down or still not doing these non-interventional trials because there's no therapy directly from the trial that would benefit the patient. And so in an interest of reducing risk, we do that. Other trials at this point, even chemotherapeutic trials across GU, are up and running. We are putting patients on. And I think that our good luck and success with our ability to keep patients from getting infected and really counseling them on their own behaviors has led to us feeling more confident now in putting them on clinical trials, even again, those that include chemotherapies. I think in standard practice, we absolutely changed what we were doing in the beginning of all of this. And for example, in metastatic hormone sensitive or castration sensitive prostate cancer, for these new diagnoses, we, for the most part, stopped using docetaxel altogether, even though we had used it relatively commonly with patients, and really switched almost everybody to the oral androgen receptor targeted therapies in combination with their ADT, because we were so concerned about giving docetaxel. At this point, I would say in that particular disease setting, we are still more commonly using the oral agents, but we are using chemotherapy in regular rates for things like muscle invasive bladder cancer and metastatic bladder cancer, certainly, and for patients with prostate cancer who need it. Testis cancer, we've always kind of held the line on that. So we're back, I think, basically to normal, but it is definitely a consideration and something, of course, that patients ask about.
Well, normal is a very relative state, I think. So we're thinking of you and offering all our support that we can from a long way away.
Well, thank you. Thank you very much.
So thank you, Alicia, once again for taking time to participate in our virtual ASM and ANZUP in conversation. Always wonderful to catch up with you, and really hope that we can do so face-to-face very, very soon.
Thank you so much, Ian, and to all the organizers for giving me the opportunity to participate, even though I'm still on the other side of the world. I really have enjoyed it. Thank you.
Thank you.